Important thing to remember is that there's 3 joints in the joint, or in the capsule.
There are 3 joints in the joint.
In a joint.
Dr. Craig Smith,
Yeah.
folks.
You should listen to me.
Welcome back to Past Your Prime, the podcast for active adults balancing life, training, and rehab. I'm Alex Kiker, pro volleyball player, dad, and a guy who currently requires a full 10-minute warm-up sequence just to reach down and pick up my 20-month-old daughter. Last week, we kicked off our master class on osteoarthritis, a joint-by-joint tactical guide. We laid down the ultimate baseline framework for how to assess a joint and find your therapeutic gap, as well as build a fortress of muscle around it. If you missed part 1, take a quick break, go back and check out the breakdowns on the SI joint and the shoulder. But today is part 2, the elbow and lumbar degeneration. I'm joined by Craig Smith, physical therapist and strength coach. Okay, next joint, the elbow. Elbow osteoarthritis. How do you confirm that the arthritis is relevant in the elbow?
This one is interesting. The elbow you have 3 joints that we want to consider. So you have your humeral ulnar joint, you have your humeral radial joint, and then your radial ulnar joint. So you have 3 separate joints that are going to be inside the capsule. So you can have motion loss in any of them. The most common one is going to be a loss of flexion relative, and also maybe a loss of extension, but you can have it in almost either direction. That's going to be the easiest sign. Sometimes you'll catch it in supination and pronation, a loss of motion. That's going to be an indication that the joint itself is compromised, along with imaging. The elbow, what's interesting is you can get tendons. I find tendons can sometimes mimic the joint tests, and that's often when people have had like a long-term chronic tendinopathy. But once you do a traction on it, it's really easy to separate those apart. Same thing with neural irritation. There can sometimes make the initial root diagnosis a little bit more difficult. But then if you see that we traction it and the motion improves, so this one I really look for a positive treatment response for reduction of pain, can be really diagnostic that it's the joint that's irritated.
Cool.
Yeah.
What, I think you just hit a couple of them, but just to make sure we're exhaustive here, what are the key signs?
My favorite one is range of motion. So if you take here, and if you're at home, you can totally do this if you want to blow it up, but a lot of people will not realize they have it. So the way that I like to test it, if it's the joint, is we'll go end range flexion, and then we'll do a lot of overpressure, and it'll feel like you're getting a deep ache in the front of your elbow.
Oh, mine hurts on the side, so that's good.
No, that's a positive. So if you feel it other places, that's also not where it should be felt. It'll almost like build. And so on this one, I'll do more of a hold on it. And then as it builds and builds, and then they come out, it's like, feels a little gross. That's your joint. Don't do that all the time. Yeah. You know which one? This is one of them where the elbows became something I saw a lot more because of CrossFit thrusters.
But that's squat, press. Yeah.
And so when
repeated motions could also be a trigger there.
But this one specifically, it's the way people they have to hold it, and then it goes back up, and they keep catching it in this end range flexed elbow position.
Is that like the med ball version?
No, like with the bar.
Oh, okay.
Or like a barbell thruster, but you'll catch it too with wall balls. You'll catch it in anything where somebody's catching it with load, and they catch it. They go into full deep elbow flexion, and then they go again, and it's repetitive. So I don't know if before CrossFit got huge, I was catching those as much, but when CrossFit got really popular, we started catching elbow irritations like that all the time. And then not only that, it's you're combining it with this kind of end range flexion with your pronated position, and people were just coming in with blown up multiple joints in the elbow, just totally irritated. And then you were catching people with arthritic joints more and more. So it is really interesting how often it happens now.
Yeah, Craig loves the trends,
dude. Oh my God. I really do, because it's also the awesome part is these dudes are moving crazy weight. I mean, that is a hard exercise.
What is this? I think High Rocks, is that the new one?
Yeah, I'm actually excited for
those athletes yet.
Well, they kind of present almost like a typical endurance athlete. They don't really they're not doing I don't see the interesting injuries on that one yet. They
'Cause I don't think they
as of other ones.
overload as much because it's like, run 2 miles, do 50 burpees, and then, deadlift a manageable weight.
It makes me want. I got to start
times.
looking at it because they haven't been as interesting as knee over toes joint explosion or CrossFitter where they do the high volume and all of a sudden they come in with a fascinating injury. So I think High Rocks needs to step up its game.
All right.
Yeah, it hasn't done the interesting ones to me yet.
We keep answering the next question every time with the previous one, but are there any other stresses that commonly overload it?
Dude, skull crushers.
Oh, okay.
Yeah, skull crushers are amazing. That's I think it's pretty similar. I do think flexion is gonna be a big one, but anything with elbow extension too, if that's also compromised.
Right. Bench press,
push-ups, anything where you're locking the elbow out and loading it can be pretty provocative. This is one of them too, where got a lot of people from jiu-jitsu who've gotten armbarred. And they keep getting armbarred.
Hyperextension.
Yeah, and then they come in and they're like, I haven't been able to extend it for a while. And that's how they look. Like they try to extend it and it's like this like weird shoulder with this thing. It's like, well, leave your shoulder out of
Relax
it. And then
a little bit.
Yeah. You have them go like this and then that's how far they can extend their elbow. And you're like, I think you're missing a bit of extension. I'm not a rocket scientist here, but it seems like there's some extension.
Well, let's have somebody forcefully put it there for you.
Yeah. What'll heal this will be I'm gonna have somebody armbar this, okay? And let's just see, because everybody has a sense that if somebody just pushed it hard enough, it would snap back into a good place. It's not true.
Yeah, I honestly wish that was the case, but I had somebody snap my wrist as hard as they could 2 weeks ago, and hey, it's just worse.
Is that true?
Well, yeah. No, I mean, you saw the video.
Oh, okay. Oh my God. I see what you're saying. Yeah, I don't think that helps.
No.
I don't think it helps. But it is funny. It is funny that this still happens.
Yeah.
I remember I had a guy when I was doing jiu-jitsu who didn't let go even when I was tapping with an arm bar. And it popped. And luckily nothing, I don't know what popped. And it hurt really bad for about a day or two. And then it felt normal. But then that amongst other reasons was a good reason for me not to do jiu-jitsu anymore. Yeah. But that's if you roll with morons. On that note, but anyway, don't let somebody pop your elbow joint either. That's an easy way to overload it.
That's never good.
Nope.
When you're starting to look at the therapeutic gap there, what's your thought process?
Well, the important thing to remember is that there's 3 joints in the joint, or in the capsule.
There are 3 joints in the joint.
In a joint.
Dr. Craig Smith, folks.
You should listen to me. Yeah. Let's put some snake oil on it. But seriously, you want to understand that you can wind up those joints in a different position. So it could be, end range here with flexion. It could be end range here with extension. It could be neutral flexion extension. So you want to know which of those different positions, combos, makes you most bothered. And then you want to work the elbow in a way that doesn't irritate those. So if I'm going to go and I'm going to do a therapeutic gap, it's the trigger management list has got to be exhaustive. This is another one where average stresses can be a huge issue because we have so many things. So if you're somebody who doesn't tolerate pronation, for example, that means every time you're typing, you're getting it. So that's where we'll do things like you have to have get a split keyboard because it'll make it so you can keep that in a neutral position. That's going to be a big one. Avoiding full extension can be a really large thing. People who sleep and they sleep by fully flexing their elbows, that can be a large one.
That was mine.
Yeah, it's wild, isn't it? Yeah, it's one of those things where if you don't think through average stresses, especially with elbow and shoulder, it can be really, really difficult because they could be handling peak stresses, which you were handling peak stress as well. But those average stresses are basically constantly overloading the joint in ways that you don't even realize. If you lay with your elbow at end range, even if you're not doing overpressure, but at end range, and you do that for 6 hours while you're sleeping, you're going to wake up hurting.
Yeah.
And then you're not going to handle anything the rest of that day.
Any taping or bracing that you use for that one?
I will use bracing. It can be helpful to keep somebody from going into full motion, which I actually think we did do with you with your elbow.
Yeah.
Using a thicker brace so you just can't fully get into full flexion or extension can be really helpful. I'll get more aggressive. There's some other braces that really limit the motion. Worst case scenario, before I've done things where I tape it to make it so the person can't move it, or I'll have them put it in something like a sling so they don't use the elbow, because it can be really difficult. We use our arms without realizing it.
All the time.
Literally all the time. Treatment wise, this responds really well to two types of traction. One is a traction just straight down, and then another one is just pulling it. So you have like a long axis traction, and then you also have one where you're moving inferior. Those work really well. It's a banded style traction that I love using on people. And then once the traction is feeling really good, I love isometrically loading this joint and gradually progressing it to where you can handle pretty significant load. And then I find that there are certain exercises that never come back. So somebody with an arthritic elbow, I don't typically ever have them do things like loaded thrusters again or skull crushers, because it's actually seems to provoke it, and then there's typically a delayed feedback loop, so people won't even realize it's happening. So it just seems like a bad exercise. Burpees, I guess you go to the high rocks thing, is actually a really common one, because people will go to the ground, and the way that they save energy, right, is you don't put a ton of resistance into your bottom, right? And so you're fully flexing the elbow underneath your own body weight and then going back up, and then they'll have this achiness afterwards, and they'll think it's muscle, and it's not. It's like you're pissing the joint off, and that's so you can have this hidden joint irritation that's happening over and over and over again.
That hits into the capacity needing to be rebuilt. What else in the extra, like what kind of isometrics are you starting with?
Well, so I think that this is kind of brings up a big one. People who have elbow issues, they typically have a grip issue as well, because so one of the important things to remember is that your medial and lateral aspects of your elbow, the flexors and extensors of your wrist and finger flexors and extensors, they cross your elbow joint as well. And so it's really common for people who are developing who have an osteoarthritis in their elbow, then develop a really funky grip pattern as well. So we'll catch people who start doing false grips to hold stuff, maybe to unload the elbow in a different way, or they'll start doing extreme extension, or they'll do kill grips because it helps to maybe stabilize the elbow in a way that doesn't hurt it. So the grip is one of them that you have to really focus on normalizing and bringing back to their attention that they're over gripping. So it's actually a really big issue. For as much motion as we can get back, I find it to be the hardest joint to get full motion back, because there's 3 in 1 capsule. So getting the rotation back, getting extension, getting flexion can be way more difficult. So I often won't get full motion back on that, which I think is kind of frustrating.
I feel like even with mine, it wasn't an OA problem, but I still feel like I'm in the very high 90% of
motion
extension.
Yeah, that sucks though, right? Like it sucks that you can't get it, but think about the consequence of that. If you pick something up from the ground, and you don't have quite enough extension, you're literally loading your bicep, which unloads the joint in a way that's going to irritate the joint. So it's realizing if you don't get full motion, we have other concerns that you need to maybe be concerned about. So we may not do a typical suitcase carry. We may do a modified, like a waiter's carry or something different, just so that we're not overloading the elbow joint too much.
Yeah, makes sense. And then how do you know it's improving?
You will start to tolerate load through it just a lot better. Typically, this is one that it's the easiest key sign is double checking flexion extension after any lift that you think would be provocative. And you'll see that you don't lose motion. You don't have an increase in achiness, and any of those triggers, they start to feel fine. So you don't have these random gigantic flare-ups. That's going to be one of the big ones. But I find the elbow joint to be one of the common ones for gigantic flare-ups.
Don't want gigantic flare-ups.
We don't want gigantic flare-ups.
Just
no, we don't.
Tiny ones. Or none.
Well, I mean, if people don't get flare-ups, I'm not sure what I would do for work.
Yeah.
Yeah.
You just podcast all the time.
Professional podcaster to nobody listening. Love that.
We're going to continue with the low back after the elbow.
Boom.
Osteoarthritis. Okay. Let's just jump right into it. How do you confirm that maybe the imaging or the diagnosis is relevant here for the low back?
I'm actually not even sure on that one. I mean, it's interesting because the spine is fascinating in that degeneration is totally normal. That you'll catch segments that seem to degenerate faster. So maybe it's I guess I find it more useful when I think of it is to think of a couple things. So there's two joints in the back called your facets. The technical term is a zygoapophyseal joint, and
Spell it.
Z.
No, just kidding.
We call it the ZAJ, but
That sounds
makes
fun.
it way easier.
Yeah. I'd like one of those.
Yeah, we're partiers. We like to party. And so I think it's interesting to think about those joints, and those can become arthritic. And then you also see at the vertebral body. So the vertebral body is going to be the
vertebrae.
The vertebrae. So you have the front part that's like the vertebra, and then you have the neural arch in the back, and you have two facets. So you can almost think of it as a pillar in the front, two pillars in the back. And so you can get arthritic in the two facets. I think that's a lot. Oftentimes people will develop, for example, stenosis. Those two facets will become arthritic, enlarged. And when they become enlarged, you can get compromise of one of the exits for nerve roots as they leave the spinal cord and the spinal canal. You'll also find that there's a structure in front of the neural arch called your ligament flavin that can become hypertrophied or bigger, and then that can actually encroach and also cause a stenosis event. And then when you look at the front, I always think you can have these different types of disc injuries that people will talk about. And so there's so many structures that can cause pain. So when somebody to me comes in and they say like, I have an arthritic spine, it's hard for me to go, oh, okay, that's 100% what you have. I mean, it's not simple to even determine which structure, especially if like everything in their spine, every level has some level of degeneration. Because you have people who come in who have what looks like a horrifying radiograph and they have no symptoms. So this one, more than any of them, I find the imaging to be dramatically less helpful, especially from a long-term management perspective. I find other clinical signs of things like a clinical lumbar instability, where they get huge increases in pain, they don't tolerate transitions and things like that, to be more concerning. And then, so just this one of all of them, I find to be the least helpful. If somebody comes in and they say that they have been told they have degenerative spine or arthritic back, I don't really find it that useful.
Okay, so this is one you kind of want to double down on the diagnosis.
Yes.
You just hit a couple of the key signs. Let's expand there. What other key signs are you looking for?
The easiest key sign is going to be flexion, extension, side bending, side to side. That, I mean, by far the easiest one. And that's one of them that's very, very responsive in session. I find it to be one of the most useful tools, because if you can, it's so easy for people to be able to use those and see if they're tolerating an activity. And then also it's very responsive to treatments. So things that you can do very easily on your own and have a really good response to it. So if somebody has told you you have a back that's broken, degenerating and all that stuff, the key sign can be incredibly helpful.
Nice.
I do have one other though.
No.
Slump test. Slump test can be useful, especially if you think there's some level of neural irritation. Can be a nice one too.
I feel like there's a lot of people out there down the street practicing the slump test.
Ooh. That's not good. Yikes.
Yeah.
They are unfortunately addicted to pretty serious hardcore drugs. And it's that is
And they're doing a forced
sad.
slump test.
Oh my Lord.
But it's a good example. It's what it should look like, right?
Well, it is crazy. I have watched some of them in some of the positions they get into. I honestly have looked up some of like what causes your ability to. So I've seen two things. First one is that they'll get into what looks like a slump position and they will hold it for hours.
How?
I don't understand it. I actually couldn't. I was looking at some of these things, and the other one is I see it at their neck, and they'll basically be in this extreme flexed forward position where it looks so uncomfortable, where I don't understand what's changing there.
Craig doing the hard research out here.
I actually
applaud to you.
I've thought about it a lot because it looks
then also,
so
like,
uncomfortable.
Are you passed out and also still being able to maintain balance?
I mean, it is.
How do you not fall forward?
I actually have no idea. I have no idea. Sarah and I were at a dance class, and we were leaving, and it was over by the Tucson Mall, close to there. And there was a guy who was clearly extremely high on fentanyl, right? And he was standing there. One of his hands was down his pants in a weird, like, it was bizarre, but he was totally out. And he was he was literally at the most extreme angle I've ever seen. And obviously,
Like you're
beyond just being
standing
sad,
folded in
yeah,
half.
it looked like it
extremely
hurt
sad, but
so
also
bad.
like just breaking the laws of physics.
I don't understand it. I really don't. Yeah, no, that actually does like completely blow my mind. I mean, what is actually happening and the changes are happening. Fentanyl is horrible. That is a total side note. Like that is a horrible drug addiction.
Weird tangent, but yeah, like
Yeah.
what physically, how are they able to do this?
I don't get it. I really don't. Like it. Yeah. Who hasn't seen those people now? You know what I mean?
Yeah, very sad.
Super sad.
Okay,
but
that's a weird key sign, but
a slump test is not quite that. Slump test is, say you're sitting, you slump, like you have really bad posture, and then you straighten one leg out, pull your toes forward, and it basically tensions your whole nervous system. And then you can compare if that feels worse throughout your activity. That's going to be a really useful key sign just in general, but it can be very provocative. So that may not be the one that you start with.
got it. Kind of already hit on it, but stresses that commonly overload.
Man, this is kind of a fascinating one because the low back is interesting. So if you have an instability, it's going to be transitions. Anything where you're going through motions and your body doesn't control it, you'll get these almost random, incredibly large increases in pain. So if you're somebody who seems like I went and deadlifted 200 pounds, and then the next day, all of a sudden, I made a small movement and my whole back seized up. That's often going to be a clinical lumbar instability. In those situations, it's motor control. It's really making sure that we're working the motor control, but it's going to be movements when you're not thinking, right? Yeah. They do well when they are doing a good job of their bracing. They're totally fine. But then there's also times where people will have a stenotic spine, and the thing that's going to bother them is going to be walking. And they develop what's called neurogenic claudication, and their legs feel like they get really fatigued and tired. And they have no back pain at all, but it's coming from their back, right?
You've made up so many words in this episode. I love that. We're going to need several diagrams to go there. But I can see that it's got to be ridiculously hard to diagnose this because I've never been diagnosed with osteoarthritis, but I've experienced so many of these symptoms and had the same type of things where, I mean, the deadlift example is very relevant. I deadlifted 275 for I think 2 sets of 5 yesterday, and last rep felt a little bit weird. And same thing, woke up and, did my little shimmy to get up this morning. I was like, oh, all right, there it is. It's still there. And
I still have something.
Yeah.
I still back.
I'm not arthritic, but it can present the same way as an arthritic joint.
Well, even to make it more complicated, you can have a disc here. You can have there's different types of disc.
It could be muscular. It could be so many other things where.
But even when we talk about disc, disc, it can be an internal disc disruption. It can be an outer disc disruption. It can be a protrusion. It can be a prolapse, an extrusion, a sequestration. So you have these different types of disc injuries as well.
Always can count on Craig to go down the rabbit hole.
And then you can have where you get a vertebral implant fracture. So the bone itself is a component of it. You could have components of the ligaments that can become painful around like your interspinous ligament, like you'll sometimes see with some people. It's called a Babcock's lesion. You can have all these different injuries. You can also have the bone being irritated, and you can have the facet joints also being painful. You can have the muscle, there's so many different pieces to it that when somebody, to me, it'd be reckless if somebody says you have a degenerative spine, there's nothing you can do about it. No. There's so much capacity inside your low back. You just have to figure out what's your triggering to make it feel worse. And then to create a therapeutic gap, there's multiple ways to make it feel better. But this, like the other ones, if you're constantly hurting it, you have no ability to get in front of this. Like if you're constantly triggering the symptoms, this is one of them that can be brutal if you don't have a good way to get yourself out of the hole. Artificial capacity works really well here.
All right, we're about to hit the therapeutic gap.
Yeah.
All right.
Lumbar brace is super useful. Understanding what triggers you, what things like average stresses give you too much. So we've talked about the tissue creep before, right? And so if you're somebody who has to sit and...
That's you. You're the tissue creep.
I'm a creep.
The tissue creep.
Yeah. That's ridiculous. But say you have tissue creep. That basically means that you're having strain to the connective tissue in your disc, which means it's changing in length over time, over its original length, and there's a time factor to it, so it stretches over that period of time, and then when you get up, it's actually the deformation of the tissue causes your pain. So then you have to control the actual tissue creep that happens. That's just one among an almost endless amount of ways that you can actually irritate it. You can also have where it's repetitive stress of the same activity. It can be a loss of control during very specific movements. So the trigger list is really important. And if you can't tell, then you want to stabilize the spine artificially or get really good at turning on your own muscles and not doing it too hard. Because another thing that we've caught is a high threshold pattern where people will turn their core on really, really hard all the time. Unfortunately, that also loads the hell out of your back. So then you can overload your back by literally firing your own muscles and you won't even realize you're doing it.
Yeah. I'd imagine the back is probably one of the, I mean, we've said all of them are pretty hard to create a therapeutic gap, but you're using your back all the time, even when you're just sitting down, you're bracing. Yeah.
Especially the start.
Yeah.
And then you can get glute amnesia, which is kind of funny. It's actually a term that's in the literature, but your butt muscle shut off because of it.
I thought you didn't like that word.
No, I don't like butt cheek.
Okay.
Or butt wink. I don't like the additional descriptor thing.
Okay.
Yeah. But say those glutes shut off, your glutes shut off, and now you actually have to overactivate your core muscles to stabilize your spine instead of your glutes helping to keep your pelvis stable. So there's all these different things that contribute to it. And so you want to make sure that you understand what we think the actual cause of the symptoms are, really, really define your trigger list. And then you don't need that many treatments to work. You need one or two things that work over time, and you will build tissue capacity, and then things that are on your trigger list will fall off. So you now it even gets easier. So this is one of them where you get in that virtuous cycle of things feeling better and your tissue capacity building. Things were hurting you before won't hurt you anymore. And you can really build capacity, which is exciting when it happens. It's like a roller coaster ride.
Thinking about building capacity, what's your progression here?
In this one, I really like to find something that makes it feel better in the moment. So the lumbar traction is by far the easiest one.
That's exactly what I went to right after I left the gym yesterday.
God, it works so well. We actually, Danny, we got to do this at some point. We were watching an influencer video on things for back pain, and it was
interesting.
It was stupid. It was weird.
Motions,
there was an insane thrusting. Yeah, and just the face he was making was weird. And it had like 20,000 likes.
Oh, can we recreate that? I just want to do a lot of thrusting.
Oh my God, none of it made sense. So anyway, I don't like those things. So for example, that'd be a stupid way to manage it by, you can't control your spine. So let's
throw it out of control 40 times.
Insane. Yeah. And this is great. It was buddy. The best part in the comments, this older lady goes, "Is this good for somebody who's 70 plus?" It's like, no, it's like absolutely not. It was so dumb. But he has a lot of followers. Oh God, I don't even know where I just got totally lost.
We're talking about rebuilding capacity through aggressive hip thrusting for 70-year-old women.
So what I think is interesting, if you can't control your spine, you want to control your spine while adding in motion at your hips, for example, or upper body. But what you don't want to do is have huge motions that you have to control. You want to gradually increase your motor control around your spine. So you do something that makes it feel good. You know the triggers are make it feel bad. You manage those two things. And then you start to gradually improve your motor control, and then you increase the challenges that the spine has to handle. And then over time, you can reduce your use of the artificial capacity tools like a brace and challenge it dynamically, increase load. That's like the easiest progression. What you don't want to do is to go hardcore on things that you can't even control that well in your day-to-day life. You don't want to put load on it and do it aggressively and hard like that guy was. It's just dumb, real dumb.
Yeah. I mean, and those weren't even loaded.
No, but they were big. Yeah, there were some big motions.
Some big motions going on there.
Do you think this is good for a 70-plus-year-old woman?
Yeah.
It's like, no.
Oh, she just roasted you, man.
Yeah. Oh, my Lord. Gets rid of your back pain.
Yeah. And then just to close out on the low back, how do you know that it's improving?
This one is interesting. I really think around peak stress and average stress. On the average stress level, you don't notice it as much. You start to do things you don't even realize that you had been avoiding before. The back, more so than anything, you'll find people will make permanent habitual changes. All you have to do is look at the sales for standing desks. Is that people have, instead of people being able to manage and master average stress, most people try to eliminate it. So you start to see people say they sit more, or they can tolerate longer walks, or they find that they've quit avoiding things that they didn't realize that they were avoiding. That's a big one. Peak stress is they feel confident and stable enough to actually load their back, and they don't feel scared when they do it. I mean, when you start to get to that point, it's actually really, really cool. And that means that things are triggering you, like they're dropping. You're getting a lot less of them. The other thing unfortunate thing is that sometimes people will stop doing the things that make them feel good because it's getting so much better. So actually seeing flare-ups in this stage where they feel really good and then they flare up can be a good sign because it's telling you that you're doing it.
Management tools for it.
Yeah.
Like, I think, once again, lumbar traction is probably one of my favorite management tools. And as soon as I knew yesterday, like I overdid it, boom, straight to lumbar traction. And, I dropped 2 or 3 points on the pain scale in 24 hours.
It's amazing.
Yeah.
Yeah. This is one though. Once if you've noticed that you've had this issue, this has to be in your body inventory. What things specifically made you feel better? What things absolutely triggered you? Because once you go through the trigger management list once, if you have a big enough flare up and it lowers your tissue capacity low enough, all those triggers are going to come back. You don't want to have to dig back into it right off the start all the way over. That's the most useful part. You want to write down all of the triggers, and you even can monitor which ones go away first, right? And then you know that it's actually progressing, which is kind of cool. That's where if you manage this well and you write down everything that was feeling bad initially and then how you start to tolerate it better, that's a really useful way for managing progress.
It's also crazy how easy it is to forget the things that helped you.
It is.
I know that you've responded to me, but like, what was helpful for this? And you're like, oh, do this traction, or, do some ERIR for your elbow, or whatever it was. And like, oh yeah, that's what fixed it. Yeah, I forgot. Sorry.
Well, no, but there's no reason unless you're actually trying to remember, there's no reason for you to want to. I feel like when people go through a painful episode, I think it's totally understandable that you don't really want to remember that much about it.
Yeah.
But if you keep that tool, I do think it makes it a lot less scary when you have a flare up.
Awesome. If you like these last 2 parts, we've got a couple other potentially arthritic joints in your body that we're considering going over. So drop us a comment below if you want to hear about those ones. If you don't, we might just not go over those because it would probably turn into a 4-parter at this point. And I don't know that our listeners want to hear 4 straight episodes about osteoarthritis.
I honestly think we'll do it anyway. Yeah.
But if you do, maybe we'll delay a couple of episodes and then throw in these additional joints that we had considered talking about. And if you've got osteoarthritis, if you've got that diagnosis and want to get it fixed, jump over to smithperformancecenter.com and schedule an appointment. And Craig will help you build that therapeutic gap to get you feeling better.
Booyah.
Booyah. One of my favorite words. Thanks for throwing that in.
Yeah. Boo-bye-boo, baby.
Peace.
If you are enjoying this podcast and finding the information useful, please consider supporting us by following the show on Spotify, Apple Podcasts, or wherever you listen.
By subscribing, you help ensure we can continue bringing you this high-level training and rehab science every single week. Leaving us a 5-star review on those platforms is also one of the absolute best, zero-cost ways to support our mission and help grow this community. Our podcast is proudly sponsored and brought to you by Smith Performance Center. If you are an active adult looking to bridge the gap between rehab and elite performance, or if you want to optimize your health from every angle, go to smithperformancecenter.com. They offer elite physical therapy, strength and sports training, and dedicated nutrition coaching to help you build a resilient body that handles the activities you love without breaking down.
If you want to connect with us, see our training clips, or watch the full video versions of these episodes, follow us on Instagram at Spiker Kiker, Craig Smith PT, and Past Your Prime Podcast. And subscribe to the Past Your Prime Podcast on YouTube.
Thanks for tuning in, and remember, you're not past your prime, you're just getting started.
PYP, baby.
Peace.
I've got it.
I can read.
I don't know. It's funny. You can read, but you can't read if people are listening to you.
I've got 2 people listening to me right now. It's fine.
It's thousands. It's thousands.
As always, joined by Craig Smith, physical therapist.
I am a physical therapist. All right.
I was doing a good job.
I think we keep it. Oh. I feel like I'm in your head right now.
You're not in my head. You'll never be in my head.
I feel like I got in your head.